Good afternoon, everyone. I would like to thank you all for taking out time to attend second CME in the series of the Cleft, Lip and Palate. Today, we have with us Ms. Renu Mehta, the Area Director, South Asia of Smile Train. Over to you, Renu ma'am.
Thank you, Aditi, and welcome everyone. A warm good afternoon to each and everyone who has joined today. So, I would like to let you all know a little about our organization. Smile Train is the largest international cleft charity. Our model is really unique. We partners with the hospitals across the country and across the world where we provide free cleft surgeries and comprehensive cleft care associated with cleft to those children who are born with cleft and are really needy and looking for this support and intervention. Over the last 22 years, we have built a very robust and system in India and have hospitals more than, I think, so there are at the moment 135 hospitals who are accredited by us, who are providing these surgeries free of cost in India alone. In India, we have supported over these years more than 7 lakh cleft surgeries. We have a very vast presence worldwide. So globally, we are present in 90 countries, and we have supported more than 1.5 million surgeries across the world. Now, to talk about the collaboration, why we are here today with Foxy, this unique collaboration of the two organizations, Smile Train and Foxy, together we have created a cleft lip and palate diagnosis and treatment protocol. So that is about my organization. I just wanted to brief you a little bit. And I would like to also, it's my pleasure to introduce Dr. Rishikesh Pai. Dr. Pai is the president of Foxy, and Dr. Madhuri Patel, who is the general secretary of the Foxy. Also, I would like to mention over here Dr. Pai's initiative, which is called Badlav. And Badlav is an initiative for each and every woman in this country. This is a unique program, which is like an overall program for overall health and well-being of each woman of India. Now, I would also like to welcome our speakers today. Of the speakers today are Dr. Komal Chauhan. Dr. Komal is the National Coordinator for Medical Disorders in Pregnancy Committee for Foxy. And she has various other roles also. She is like an accomplished professional. And we have Dr. Puneet Batra. Dr. Puneet Batra is an orthodontist and has been associated with Smile Train for a long time. He wears various hats. He is an orthodontic practitioner, teacher. He is a Smile Train Medical Advisory Council member and also a research council member. So I will now hand over to Dr. Komal Chauhan to take the proceedings forward. So over to you, Dr. Komal.
Thank you. Thank you so much, Dr. Renu Mehta. And at the outset, I would like to thank Dr. Rishikesh Pai, President Foxy, Dr. Madhuri Patel, Secretary General, for this unique collaboration with Smile Train. You know, it's a real good thing to take and discuss every aspect of pregnancy and the postpartum period. So it becomes very important to know certain topics which are not discussed earlier. And topic like cleft lip and cleft palate is very rarely known or discussed. And patients, they feel obstetrician as their first doctors, and they keep coming to us with a lot of queries because they're after delivery also their babies have so many problems, and they really have that bond with obstetrician for the 9 months. And when they come again and again to you, you should know what is in your purview. How can you give best diagnosis of cleft lip and cleft palate to when the patient comes, how you can counsel that patient, how you can guide her in this journey, how you can refer her to a specialist. All that becomes a real challenge for the obstetrician. And my talk today is going to focus basically on these challenges and what is in the obstetrician purview. How would we know when would be the surgeries done? What kind of special care require? can we, can we really, how can we maximally help these patients and guide them to like Smile Train or certain agencies who are working so focused on these cause of cleft lip and cleft palate. So I am from Mumbai. I belong to Mumbai and have been the chair of Medical Disorders in Pregnancy Committee, FOXI. And I will now begin with the topic. And this is just a thank you to Dr. Rishikesh Pai, Dr. Madhuri Patel, as well as the team Science Integra. Subbu and his team, they have brought us all together for this cause. And I'm really happy to be part of it. I will start with today's topic. Cleft lip and cleft palate, the diagnosis, management, and the obstetrician purview would be discussed. So I start with the quote from APJ Abdul Kalam. The purpose of education is to make good human beings with skills and expertise. Enlightened human beings can be created by teachers, and we always require teachers who guide us all throughout our career and our life. So today's discussion points, we will discuss all these, that is recap of embryology, relevant anatomy and pathophysiology, the classifications, counseling of parents, basic repair techniques, and what is the obstetrician role. So when we talk about a facial cleft, it is a most common congenital deformity. We see that it is really a commonest one, a second commonest one, affects 1 in 1,000. And the problems can, right from the cosmetic, the way the child looks, till the developmental issues, till the emotional issues, the problem become endless. So let me just recap you to the embryology. We can see this picture. This is the frontonasal prominence, and below is the mandibular prominence. These are the two maxillary prominence, and this is the lateral and the medial nasal prominence. So this all are very important when you need to remember when we're talking about the embryological development of a cleft lip and a cleft palate. So what happens? The fusion defects are the main thing which can happen between any of these prominence which we just discussed. A defect in fusion between the frontonasal and the maxillary will cause a cleft lip. So this will be a cleft here. So frontonasal and maxillary will lead to a cleft lip. Now coming to the cleft palate, the development of the primary palate, it starts very early in the gestational age. That is at 4 to 8 weeks. And we know there is a primary palate, which is a triangular part of the hard palate anterior to the incisor foramen, and which originates from premaxilla, which is also called as frontonasal prominence. And then at 8 to 12 weeks, the secondary palate, that the remaining half of the hard palate, it starts developing. So the development is in two different stages. So this is how the fused palate will look like, and the palate is getting fused. This is the normal thing. So when we know that there is a cleft lip and cleft palate, the complex mechanism of all these features, that is swallowing, hearing, speech, breathing, all become impaired. The unit has feeding difficulty, and this has a great impact on the postpartum period of the mother also and of the child also. And a cleft makes the creation of negative pressure, and that is the reason feeding is really very difficult. Then there is eustachian tube dysfunction. Secondary defect of the tooth development, there will be dental problems. I have Dr. Puneet Batra, who is talking too much about the dental problems. And all these will definitely have a psychological impact on the mother as well as the child, how the child's growing. Now, coming to the prenatal diagnosis, what is there in our thing? Yes, prenatal diagnosis, cleft lip can be diagnosed in second trimester. So as early as 13 weeks to even later, we can diagnose cleft lip, but a simple ultrasound, it may not pick up every single case of cleft lip. Or cleft lip can be picked, but cleft palate, it can be little difficult by an ultrasonography. But what is important is a 3D. 3D will definitely pick up these cleft lip and cleft palate anomalies, because 3D has an upper edge. And here, seeing the facial like a picture, this 3D sonography, we can pick up cleft lip and cleft palate. This is by the 2D how it will look. So coming to the etiology, we really don't know exactly, no one knows why this occurs. Multiple factors have been shown to cause. that it can be an genetic, inherited from any of the parents, or the environmental factors, maybe the environmental things which are affecting our genes, drugs, steroids, or anti-inflammatory, classically the anticonvulsants, phenytoin, then rubella, infections which are there in pregnancy, and rubella, one of them, is a very common to cause all these fetal implications. Then drugs like alcohol consumption, smoking, all these addictive drugs, hypoxia during pregnancy, or multivitamin deficiencies, all can cause even advanced maternal age. So we really need to know that there would be a high risk factor, and these can be one of them, or combined factors. But or there can be absolutely no cause. It can just occur all of a sudden. So the problems associated with cleft lip will be the feeding, which will be more evident immediate postpartum. Then the dental problem, deformities, which requires aesthetic correction. In addition to that, there are ear problems also. Speech difficulty, articulation is difficult, and there can be associated anomalies. Maybe it's not always a cleft lip and cleft palate will be only abnormality. It can be associated with other abnormalities which require correction, or that also requires to be addressed. Feeding difficulty. This is the most commonest, and cleft lip makes an infant very difficult to suck on a nipple. And cleft palate, even if we definitely cannot, the suckling is affected, but if the breast milk or a formula, any milk, the cleft palate, there is inability to create the negative pressure. And that is the reason there are frequent regurgitations. And the oral cavity, there are repeated infections, respiratory tract infections. Also, there are n number of dental problems, and from the dental problem of missing tooth to hypoplasia, even the bone, whatever jaw is also affected, all orthodontics problems, and all these, I think Dr. Batra will speak in detail. Talking about the nasal deformities, this facial disfigurement, everybody, I think the parent first, they see a baby born with a cleft lip, they're really very, you can see their faces, because the disfigured face, really, they feel really sorry, or they cry from within. So the poor nasal shape, scars, later on, even if the corrections are there, scars may take very long time for healing. The lip function also will have poor, the speech or the articulation will get affected. The smile will not be a correct smile, how it should be. And that all can become an issue later. So this is generally the classification where we have group 1, where it's only a cleft lip. 1A is a cleft lip and a cleft alveolus. And group 2 is a cleft palate. And group 3 is all combination, a cleft lip, cleft alveolus, and a cleft palate. So this is how it will look. This is the classical only cleft lip picture. This is cleft lip with cleft alveolus. It is extending till the nose. And this is only the cleft palate. You can see how the cleft palate classically looks. So knowing the anatomy, this is the philtrum column and the philtrum dimple, and this is a white roll. So actually, you can see how this is getting affected. There is a shifting of the white roll and the tubercle, and this is a complete shifting. The white roll has got shifted completely, and this is how it can cleft lip associated with cleft palate. So when we have to take a proper history, we need to know what problem the child is facing. We have discussed many of the problems, but also to add to it will be malnutrition, because the feeding becomes very difficult. Failure to thrive, failure to gain weight. So all these is very important, apart from the disfigurement and the infections. So how do we take care of this newborn? We need to have a special care for this. Cleft lip, infant is not able to suckle. So you need to use special nipples so that baby can latch, or you can use a pump, and then you will have to feed in a specific designated way. Cleft palate, even if there is a formula or a breast milk, it can be taken up to the nasal cavity. So we don't feed the baby without palatal obturator, that is prosthetic palate. It can be put to the baby, and it needs to be fed only in upright position. Because if you don't feed in upright position, then there can be regurg, and all the food or the milk can come out from the nose. And this becomes a very difficult situation. So these counseling is very important. The proper technique. These are the special feeding bottles by most of them necessary that breastfeeding were providing. So giving a special bottle, making the baby sit in upright position. This is very, very important. It is always important to have an upright position. So there is no regurgitation of the milk, even if the baby is taking a bottle feed. Burping following feed, very, very important classically. Even if you are using a spoon vati, you should not allow the baby's head to fall back. Upright position is a must so that everything goes down immediately. And cleaning hygiene, that is very important, whichever method they choose to do. If breastfeeding is actually preferred, and we tell all our patients to advocate breastfeeding, but here is a special care in which the baby is not able to latch. We can provide, but we really need to monitor the services what we are giving to the patient, the hygiene factor, everything needs to be taken care. So what about the surgery? Because soon they see a disfigured baby, they will ask obstetrician, "Abhi kya karna hai? What to do? What can we do? What is the option?" So they are very eager about surgery. So when will it be done? Where to go? All these questions come into the mind. So definitely after a clinical evaluation and everything, the basic investigations also needs to be done about the speech, whatever the baby has developed, because nothing is done so soon. So all the lateral views, that is lateral, frontal, video fluoroscopy, the flowmetry, cephalometry, all the with the OPG, all everything is done, and then the assessment starts. Assessment initial is at birth only, is a pre-surgical first assessment, but the surgeries are not a simple single surgery. There may be a primary repair, at around 3 months. Then there can be palatal repair, which can take around at 1 year, 9 to 18 months. Then later on, they require a lot of speech therapy, then revision surgeries, even bone, if there is a deficiency in bone and alveolar bone grafting and all. So all it becomes a complete follow-up till in the growing up years. So this requires a proper management. It is not only a single thing. So pre-surgical, if you do some orthopedics, this will be all discussed in the dental talk. So I'm not going to go into detail. And these are the surgeries just to show that how the correction can be done. It is Randall Tennyson lip repair and Millard's rib repair. But timing, this is very important. So you early repair, what you do, if you do it early, that is ideally, that I said it is done after 3 months. So if you do it early within 24 months, speech and the hearing actually improves. And even also it delays the mental retardation also. So suboptimal time of the palate repair is 3 to 6 months. And if there is a hard palate, then 15 to 18 months, you really need to little wait till you do the palatal repair. And this is how the palatal, that is VWKL repair, can be done. And these are the intervelar or Furlow's palate repair, which is commonly done. So now coming to the obstetrics purview, what about the genetic evaluation? We spoke about deformity, we know, and we are obstetricians. So do we can prevent? How do we evaluate our pregnant nations? What are the counselings and referrals once you diagnose it antenatally? Is there any scope of fetal surgeries? And apart from what we spoke, how best we can help them postnatally and prenatally also. So definitely a genetic testing should be offered to all patients with fetal oral cleft, because this information will be really important in their decision making, whether to continue the pregnancy, how would be the postnatal period. They should be prepared for the care which they have to give to the child after birth. Also, we need to know that is there any multi-syndromic, like some family history or some high risk factor or something which is there associated with this pregnancy, or it is just a sporadic event. So this is a very important when we are counseling, giving genetic counseling. Sometimes you feel that it may be associated with other anomalies. So screening for common trisomies is so important when you see some isolated cleft lip or cleft palate on an ultrasound. Then after you have found out, refer to where the neonatal services would be there. It's always better that the child gets a special care where there is a proper neonatal service. So delivery can take place, or there should be a provision to shift the baby immediately so that a proper evaluation at birth is done and everything can be parents can be counseled. Really, the team is already ready because we know that we are going to have a problem, a baby with a problem. So planning, surgery, everything, counseling. So they all are in it, the decision making. It becomes very easy for the obstetrician as well as the parents. Then we require, actually, there is a craniofacial management team. And here the pediatric, genetic, even the nursing care, nutrition, because the baby needs nutrition, oral surgery, dentistry, orthodontistry, or otolaryngology, plastic, reconstructive surgery, and psychology. So obstetricians should be prepared that this is going to be really a multi disciplinary team, which is really required so that the development of this child is taken care. Now there are so many studies which shows about fetal surgery. So repair of this oral cleft in surgically related animal models have shown to be successful. And when they are corrected very early, the fetal, so there is a scar-free healing, and then normal development of face, skull, everything happens. But will this be possible in humans? It's yet to be known. We still have to know. We still have to have more studies. And there are these surgical techniques nowadays done very nicely in excellent hands. They are done. So I feel going an in utero correction, because it is not a life threatening disability, it is just going to have little impact on the quality of the life. So going in utero and planning a fetal surgery may not be a viable option. Definitely, prenatal care after delivery is so important, and we need to give patient a good antepartum and an intrapartum care. And sometimes, because of the fetal swallowing difficulties, there can be complications like polyhydramnios. Mother will have polyhydramnios, which can lead to preterm labor, which can have early, problems in pregnancy, and even premature rupture of membranes. So these also can have an obstetric implication with the babies having this cleft lip and cleft palate. So birth should always occur in a hospital, and the neonatal needs should be met. The mode of birth also should be actually be individualized on obstetric consideration. It is not necessary that a cleft lip palate or cleft baby needs any vaginal delivery or a cesarean or anything. No, it has to be only solely on the obstetric indications which we come across. We really don't have to do anything elective for this patient. So I will end with a quote: optimism is a faith that leads to achievement, and nothing can be done without hope and confidence. And we really need to have this optimism when we counsel our patients with cleft lip and cleft palate. And I thank you all for your patient hearing. Thank you. Thank you so much. And if there are any questions, I'm open to all the questions before we hand over to Dr. Batra. So I can see Dr. Batra, who is already joined, and there are few questions. I think they all look mainly addressed to Dr. Batra, because it is all for the treatment part and not related to the obstetrician part. They have asked one question about feeding, that how long only liquid should be given and when to start semi-solid and solid diet. So this is after surgery. So I think after surgery questions would be all, and regarding the mouthwash and everything. So I think we can hand over to Dr. Batra so that he can take over the treatment part, because we are more interested in knowing what happens and how should be the follow-up and everything. So over to you, Dr. Batra.
Thank you so much. I'd like to share my screen. So today, I'll be talking about oral health issues in patients with cleft. Is my screen visible? Yeah. So, but there are two different issues. One is the orthodontic management of these patients. The other is the more important point, which I want to highlight today, which is about oral health in patients with cleft lip and palate. Because, this is one issue which is often underlooked because we are undergoing different phases of treatment. So FDI, which is the World Dental Federation, defines oral health as being multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. So, when we are talking about the social determinants of health, it becomes very important that oral health is taken care of. Well, oral health involves a few things, and I'd like literature. This is, an article 15 years ago which talked about the knowledge of oral health care for children among gynecologists and pediatricians, which says that there is a need to educate, because all of us are specialists and we are, in our own fields. But when it comes to interlinking, many times there is a need for each other to be on the same page. So oral health associated in children and infants with cleft needs to be tackled in a very, very precise manner. Like the speaker before me talked about feeding in cleft children. Now, one needs to take care that whatever feeding technique you are employing, the child is fed well, but oral hygiene is very critical for these patients. Removal of any of the remnants of the milk, which is lying at the cleft side, needs to be a priority. So when you feed the child, the last bit has to be boiled and cooled water from the bottle, because all the remnant of the milk which is lying will mix with the mucus separations, forming a hard crust, which can be a source of infection. So, as soon as the child is born, we need to habituate to use a damp cotton bud or a wet gauze to clean the gum pads as well as the cleft area. Many times the parents are a little bit conscious and they are a little bit afraid to venture into that area. So an orthodontic or a dental visit can make it easy for them if they find it difficult. But however, it's not that difficult at all. The first process which was mentioned was pre-surgical infant orthopedics. Now, pre-surgical infant orthopedics further, couples up with, an issue, because now this appliance, which is there in the mouth, you can see the picture of the appliance in the lower left part of the slide, is an acrylic appliance. So it has a tendency to adhere more milk remnants and also more candidal and other bacterial growth. So we need to remove the appliance and wash it in cooled boiled water. It should, not be in boiled water. Usually, Indian mothers have the habit that they'd like to boil and, keep it clean. But this appliance can get distorted if it is boiled. So, we have to use boiled water, but which is cooled, and then clean up the appliance using a moist swab stick to clean the area of the appliance, and make sure that white paraffin is applied in the lip area so that no ulcers are formed. If there is ulceration, bleeding, and tooth eruption will be hindered. Now try and understand that, children with clefts are likely to have dental complications because of the natural, ecosystem within their oral cavity. First, there are a number of dental anomalies which are very common in cleft children. Second thing is that dry mouth is also quite common. Less natural cleaning, because, the areas of the interdental part where there is a cleft defect is not allowing natural cleaning process to happen. Also, there is increased tendency for consumption of sweetened products as well as delayed oral clearance time. So there is a tendency for having early childhood caries, gingivitis, periodontitis, and malocclusion. So, from the dental perspective, these four words need to be, understood very well. One of them is caries. The other is gingivitis. I will be explaining all of them in very simple terms: periodontitis and malocclusion. Now, caries stands, it's a Latin word which stands for decay. So early childhood caries is defined as the presence of one or more decayed or missing teeth or filled tooth surfaces in a primary tooth. Primary tooth is a milk tooth. So, usually there is a tendency to ignore the milk tooth. We need to understand that these milk teeth are nature's space maintainers for allowing the permanent tooth to erupt in the right direction. So they should not be lost early. If they are lost early, it is a loss for the further treatment for the cleft child. Now, what is the role of plaque in dental caries? Try and understand that plaque is a biofilm of acidogenic bacteria. So these bacteria, like Streptococcus mutans, stick onto the tooth, and when free sugar food is taken up, what happens? An acid is produced. Now this acid lying on the tooth surface leads to demineralization. So this demineralization leads to tooth decay. Now, so it's a combination of the diet we are eating, the biofilm. If we are cleaning this biofilm well, the bacteria will not lodge. So all of this milieu is quite common in cleft children. So dietary fluoride intake is important, along with advice for fluoridated toothpaste. So water fluoridation has become part of many countries' policies, where water is fluoridated because it leads to better health for the bones as well as teeth. Now, healthcare providers should try to prescribe sugar-free medications and pacifier use should be discouraged. Now, keep an eye for demineralization. Demineralized areas are those areas which have lost calcium. So these areas become more prone to dental caries. So you can see pictorially that you can look for brown spots on the teeth. Some of these spots are just extrinsic. They are on the outer surface because of improper cleaning. But the ones which are intrinsic, which are inside the teeth, are not the cause for worry. Extrinsic discoloration can be caused by chromogenic bacteria as well as dietary factors, and these are usually in adults. You will not find them in small babies or smaller children. And mouthwashes can also lead to discoloration. So, you need a good oral hygiene provider to decipher why these stains are there on the teeth. Dental fluorosis looks like this. So, in areas where there is more water fluoridation, this is the kind of picture you'll find. There might be defect in the enamel, which is quite common in cleft children. That you can see, tetracycline stains, and you can see pulp necrosis, but the brown spots on the surface can be carious. So they need to be assessed and properly diagnosed. Now look at the cycle. Stage 1 is a small cavity that's black on the surface of the tooth. This progresses to stage 2, where the pulp is involved. Stage 3, when it becomes even deeper, and finally the tooth is extracted. So already in cleft children, oral health related quality of life and dental caries is an issue. So, the impact of orofacial appearance on oral health related quality of life, there is a moderate impact for orofacial appearance dimension on the quality of life in patients with different conditions with aesthetically related treatment need. So, this is adding on to the burden of care, because this will require a long process to be done to rebuild what has been lost. Now, what is gingivitis? Early stage of gum disease is called gingivitis. What is that? The gums around the teeth become red, swollen, and bleed when brushed. So, the first sign of blood on the toothbrush or after spitting is a sign of gingivitis. Now, I often, equate it to a child who wants to say, a child wants to tell his mom that he's hungry, he cries. So how can our gums tell us that they are upset? We are not cleaning our teeth well. Is by blood, which is on the toothbrush or at time of spitting. We might also have bad breath, which is called halitosis. So what needs to be done for every cleft child is to encourage to maintain good oral hygiene, regular dental checkup, and encourage professional cleaning and scaling. So, if there is any deposit which is there, can be removed with the dental person removing the deposit. Now, advanced stage of gingival gum disease is called periodontitis. What happens now is that this plaque layer, which is forming along the gum margins, is causing a damage to the bone support around the tooth. So these teeth become loose and will be lost over a period of time. So, this is a silent disease. It's not going to, pain you, and soon you will realize that your tooth, which was strong in the bone, has lost its bone support. Now, how can you prevent gingival and periodontal disease? good oral hygiene, such as good toothbrushing, interdental cleaning, regular dental checkup, and professional cleaning and scaling. Also, empowering people to take care of their general and oral health and promotion of behavioral change. Now behavioral change is a simple thing. Like many of the kids will brush only in the morning. Now I often, joke with the mother. I say that, if you will brush only in the morning, it's like, a storm has come in our house. So there's a lot of dust which has come. Now we say that since we cleaned our house in the morning, we are not going to clean it again. This is not right. What needs to be done is a regular night brushing. So, this has to be encouraged right from the beginning for any child to have good oral hygiene. Now, cleft children also have multiple missing teeth. They have some extra teeth. They might have impacted teeth. They may have small sized teeth or malformed roots. So, this is another factor which makes life difficult for the child because, cleaning in these type of teeth is more difficult to do. But if we maintain good hygiene, we can have a good orthodontic outcome as well. Now, what is the cause for premature loss of milk teeth and consequences and clinical management? You might have developmental anomalies. These might be small sized teeth. There may be premature resorption of their roots, and these might be extracted because of caries. Now, what will happen if a tooth is lost? They are milk teeth. How do they matter? Loss of teeth will lead to crowding. It will lead to problems in speech, psychosocial issues. The midline, the center line of the teeth will shift and will cause crowding. So, there will be a number of further sequelae of treatment required to get a good outcome. So, my emphasis today is to talk only about oral hygiene. Why all the orthodontic treatments which we do, we align teeth in the mixed dentition to prepare them for an alveolar bone graft. Now, if the brackets and the appliances, orthodontic appliances are there, it will be even more difficult to clean. So, as a mother, while you're still, you have to deliver the baby, you as a mother have to take special care because your gums will bleed more because of hormonal change. So you need to brush yourself twice. You need to change your diet to a low fat milk or choose water. Also avoid carbonated beverages during pregnancy. Choose fruit rather than fruit juice to meet the recommended daily fruit intake, and obtain proper dental counseling at the time of delivery. However, for the baby, we have to ensure that we supervise when the children's teeth erupt, we need to supervise their brushing. For a baby, a small amount of toothpaste as big as the size of a pea needs to be put so that it's not swallowed inside, right? Also, we need to limit sugary foods to meal times only. There should be no in-between meal time binging on sugary foods. Avoid saliva sharing behavior. Like, you are seeing that the food is, what we are feeding is hot. You are tasting it, and then the same spoon is used. So avoid that, and visit a dental professional every 6 to 12 months to ensure that there is whatever initial caries has happened, we are able to salvage it by a small restoration rather than it progressing to deep caries, to requirement for a root canal and a crown, and then finally extraction for that tooth. So thank you very much for a patient hearing, and I'd be very happy to answer any questions regarding upkeep of good oral health in cleft children.
Can we have the questions in the chat box? I can see questions related to surgical management. I think that was not the purview of your talk about the feeding. The one question is from Kamlesh Singh. He's asking, what is the role of mouthwash, their selection and regime for these patients?
Yes, this is a very good question because, there are different mouthwashes for different problems. If you have a tendency for caries, you'd like to use a chlorhexidine mouthwash. If there is a regular fluoride toothpaste is a good idea to help in prevention of demineralization of the teeth. However, if there is periodontal disease, a hydroxyl or a mouthwash which is, preventing infection in those regions is a choice. So that choice of the mouthwash should depend on what is the problem. So, for example, in periodontal disease, you'll use a hydroxyl mouthwash. But upkeep of good oral hygiene will only prevent the bone loss. The bacteria which are there, they need to be cleaned up first, and then the mouthwash is like a maintenance.
So that's good, because I think oral hygiene needs to be really very well maintained, because infection is a concern, and there are questions related to the food. So when they're using, can they eat the normal food, the semi-solid or the solid? How do we guide them regarding the diet?
Right. The question is that, when the orthodontic treatment is going on in the mixed dentition and the permanent dentition, there are some restrictions on eating hard diet, because the braces are stuck onto the tooth, and with the wire, we are moving our teeth. So we do not advise the children to eat on hard things. They can modify their way of eating and not to bite from the front teeth, because, the anterior teeth have they are single rooted, and especially the lower teeth have smaller roots. So when you are undergoing treatment with braces during your mixed dentition and permanent dentition, and you are biting from the front teeth, you are in fact causing damage to the root of the teeth. So I give a small example. You are running very fast, and there is a small stone on the way. What will happen? You will trip and you will have a bigger damage. But you are walking and there is a small stone. What happens? Even if you trip, you are able to balance. So the balancing act is that avoid hard things while you are undergoing orthodontic treatment. But as such, there is no restriction on eating. What I suggested was that, binge eating every 2 hours, 1 hour, and taking sugary, things. You want to have sugary things. I have a sweet tooth. Eat, do a mouthwash. You just take some water, rinse your mouth, and leave it, because the sugar which you are taking, the bacteria are acting on that sugar and creating an acid. So if that stays on your tooth, it is demineralizing it. So that's not healthy, because over a period of time, it is going to lead to tooth damage.
Yes, so I think this needs to be very clear. Also, all these treatments which they have to take, what is the duration span? How long they have to follow this orthodontic?
Again, beautiful question. The first thing is that pre-surgical infant orthopedics is started at birth. Okay, and it is still 4 to 4.5 months. Why? Because the mother's estrogen is there in the nasal septum of the baby. Now, only that much is the time in which you can do molding. Plasticine, we can shape it into any shape we want. Similarly, the nostril as well as the alveolar segments can be molded only during the first 4 to 5 months of birth. Okay, that's because the mother's estrogen will gradually decline, and by the end of the 4th month, it's almost zero. So the pre-surgical infant orthopedics is usually 4 to 5 months. The mixed dentition treatment usually lasts from 1 year to 2 years, depending upon the stage and what is the treatment which is being done. So, this treatment is done to prepare the patient for secondary alveolar bone grafting. The permanent dentition, the braces which are put, are again usually lasting about 2 years of treatment. So, it's a long treatment. It requires the patient to come once a month for activation of the appliance. But, the comprehensive treatment is similar to any treatment done for a child who is at that school age growing. So, that's just like a routine orthodontics, but of course, more difficult to do because of the scar of the palate, because of multiple teeth, missing teeth, and a lot of dental anomalies.
So, there are not any other questions. The team, can you post? I think your talk was so comprehensive, and you focused so well on the hygiene, and it is quite clearly understood. So I think it was a great session. Your take, Dr. Renu Mehta, on the talks?
Yeah, absolutely wonderful. And even if the audience has questions which are relating to, I could see there are feeding questions, there are which we could not address here because you all have your specialities that you were addressing to the audience over here. But yes, a very good session, very detailed, and I would say this is an unending topic. So there could be, but I would urge everyone to don't feel shy, ask questions, because unless and until we discuss this, we are not going to address the issue of which is very, very important, that cleft lip and palate is such an anomaly that it should not be discussed. It should be under closed doors. Oh my God, my child is born with this. Now, what is going to happen? So, you, as the obstetricians and gynecologists, are the first touch point for the mother, for the cleft child. So, the role that you play in the life, it's like the foundation has to be strong for the building to be set up. So if that is addressed at the right start, I would feel the mothers would come on time, take proper counseling at hospitals. So ask questions. We have a toll-free number, Smile Train, where we address all the questions, whether it's related to child's health, where to guide the child, where is the nearest Smile Train partner hospital available, whether this cleft specialization like speech, orthodontics, nutrition, how to address that. So the toll free, I would like to repeat my toll free number over here. It's 1-800-103-8301. So if you have any questions, I am very sure that the Foxy team, Smile Train team, our advisors, Dr. Puneet Batra, as I mentioned, is one of the India Medical Advisory Council members. So on the council, we have surgeons, we have speech pathologists, we have anesthesiologists, we have nutritionists, we have pediatricians. So any questions that you have, smiletrainindia.org, you could write to us. We would be able to help you with that. So yeah, overall, I would say a very, very good session. And I would have loved more questions. I would also like to share that Smile Train has a feeding video. It is an animated video, which is available on our website. So any feeding related questions, you could go there. You could also ask us to share. We have developed this nutrition booklet and handouts for patients and families, that if your child is, say, just not taking top feed at the moment, it's just 0 to 3 months, what is to be fed, 3 to 6 months, what is to be fed, and pre-surgery, what care should be taken care of. So we have that information available. Yeah. Is there any other question, or Komal, what you want to do now?
Yeah, the team, Aditi and the SI team, are there any questions? Actually, nothing forwarded to me. I've already asked what was forwarded. I think there are no more questions. That shows that the people have well followed the talks which were there.
So that's really wonderful. So yeah, on behalf of Smile Train, I would like to thank each and every one of you who's present over here today. Special thanks to Foxy, especially to Dr. Pai, Dr. Madhuri Patel, and you, Dr. Komal, because you were providing in such a manner a complete perspective from the obstetrician side. Dr. Puneet Batra, once again, for briefing all of us on oral health issues. And a special mention and thanks to the team of Science Integra. So yeah, thank you so much.
Thank you. Thank you.
Thank you.